And that's why I would never recommend to anybody with PCOS. It's just not going to help your symptoms.
It's going to become a driver as well.
And that's actually the most effective form of emergency contraception because it's the way that it works.
That can really reduce that effectiveness from 99%, we typically see, to about 92% effective.
People think, okay, I've taken the ECP once this month, therefore I can't get pregnant. That is not how it works. It's just going to delay your ovulation by a couple of days.
It was just kind of scared into us that you'd gain so much weight you were taking them. So I think everyone was just sort of like, maybe not.
It is one of those teach a man to fish type scenarios. Once you've learned how to use it, it is a skill set for life.
It is just a skill set that you will just use and use until menopause.
Hello and welcome to PCOS Explained, formerly the PCOS Nutritionist Podcast. I'm your host, Claire Goodwin, a registered nutritionist and exercise scientist, specialising in PCOS because I have it too. Each week we'll uncover the latest research, share inspiring stories, and provide practical tips to help you thrive with PCOS. Whether you're newly diagnosed, you've been struggling with this for a long time, or supporting someone with PCOS, this podcast is your go-to resource for empowerment, education, and community. So join us as we uncover the tools to thrive with PCOS. PCOS Explained is brought to you by our very own service, Ovi. Ovi is your go-to health service for women with PCOS. We help you improve your PCOS symptoms and prevent the long-term complications of PCOS by giving you hyper-personalised health advice based on your specific symptoms and PCOS drivers. We have a range of plans to suit your needs, from a DIY app-based program to one-on-one consultations. You choose what suits your budget and learning preference. And we offer a result-based guarantee on our Premium Plus plan, meaning that if we don't help you achieve your goal, we refund your money. Ovi is available worldwide, so it doesn't matter whether you're based in the UK, US, Canada, Australia, New Zealand, or anywhere else, we can still help you. So today we're talking all about contraception and all your contraception options, from hormonal, oral pills, implants, non-hormonal, barrier methods, permanent methods, semi-permanent methods, the lot. So that you can make an informed choice about what works for you and your body. So let's start by actually talking about how do we get pregnant? Because I think this is something that you might be listening and say, well, duh. But actually, when you understand the physiology of how you get pregnant, it helps to understand how these contraceptives are working.
Well, Claire, the birds and the bees. No, really, what happens is...
Didn't you just write a book called Getting Pregnant with PCOS?
Yeah, tell me more. So what happens to get pregnant is, as a female, we release an egg once a cycle, and we need, to get pregnant, sperm there to be ready waiting in our fallopian tubes to fertilise that egg. So that's what happens if the sperm is there, and it can last inside us. Some super sperm can last up to 5 days within us. So any time between kind of those 5 days, if that happens, and times quite perfectly with when that egg is released, there's a chance for pregnancy there. And that's kind of what no contraception would allow to happen. So we kind of need to think about it. What can we do if we don't want to get pregnant to stop the sperm and the egg meeting at that perfect time when the egg is released? So there's a few different options, but the first one, when we look at, say, let's start with talking about hormonal birth control, oral hormonal birth control. So this would be, let's start with the combined pill. So that's going to have estrogen and progestin, not progesterone, but progestin, the synthetic form. So that's what we would take. And together, those two hormones are going to alter our physiology in some way. So because of these hormones, we're going to not ovulate. The egg actually won't be released into the fallopian tube. As well, the progestin is going to work to thin our uterine lining to stop that egg from burrowing and implanting into our uterus, which would happen if we were pregnant. And then we also thicken the cervical plug, or the cervical fluid that plugs our cervix to our uterus, so that sperm really struggles to get through that barrier. So we're kind of creating this hormonal change where we create a internal barrier for the sperm. We don't allow an egg to be released, so there's no egg for the sperm to meet should any sperm get through. And even if both of these things happened, would be working on thinning that uterine lining as well. So, yeah.
So it's like there is a 3-pronged approach to make sure that sperm does not get through.
And how effective is the combined?
So the combined pill is 99% effective in perfect use. So that means that for every 100 people that use the pill perfectly, only one person will get pregnant per year, or per 100 people, right? So it's pretty effective, right? Really, really, really effective.
Yeah.
But it is changing the physiology of our body. And we're not going to go into all the pros and cons for you, because this is definitely a personal decision based on your symptoms. But if you're wondering, am I on the combined pill? You probably are, right? It's the far more common pill.
Especially if potentially you've been prescribed this and your doctor said this should help with your PCOS symptoms. They're probably going, not always, but probably going to put you on a combined pill.
Yeah. Just a little side note of that, talking about how it stops you from ovulating. So this is why when you might have been told that going on the pill is going to regulate your cycle, that's, as you can probably see now, that's not really true. It will give you a regular bleed, but...
Should you use the
you use the sugar pills? But what it's doing is it's completely flatlining your hormones. You actually aren't producing any of your own estrogen and progesterone, and therefore you are not ovulating or producing an egg, which is how it works as a contraceptive. And as a contraceptive, incredible. So if we're not actually ovulating, then we're not
having a cycle, right? Yeah.
Because that's the whole kind of point of the menstrual cycle, is to ovulate.
Like the ovulation is like the peak of the cycle, right? Yeah.
And the only reason we're getting a bleed is if we take those sugar pills, which mean that we get a withdrawal from the synthetic hormones that we're on. So that's why if you just stack your pill packs together, why you probably won't get a bleed for many months. So this is just, it's how it works as a contraceptive, and that is incredible, and it's an amazing contraceptive. But in terms of actually regulating ovulation,
regulating a cycle.
Regulating a cycle, which is otherwise should be known as regulating ovulation. It is terrible at that, because that's its whole purpose, is to stop you from ovulating.
Yeah. So I think we're always really conscious of the language used around this, and we do get really upset when we do hear, doctors or like educated people saying this will regulate your cycle, because technically the cycle isn't being regulated, it's being shut down. Yeah. It's just regulating a bleed.
Yeah. The way that one doctor described it to me is, actually you can think about the pill as putting your body into a false state of pregnancy, even, because it is blocking that estrogen and progesterone, and therefore not allowing ovulation, which would be exactly what happens when you're pregnant, because you're not producing an egg when you're pregnant, because you've already got a baby. You don't need to produce any more eggs until that baby's born.
It's kind of like a feedback loop.
Yeah, exactly. It's like, whoa, no need for this to happen here.
We don't need to be wasting our energy popping out another egg. Go on cooking already.
Exactly. So that's a combined pill, and it does contain the estrogen and progesterone. And all the different brand names basically represent different amounts or different types of those two drugs. So like your Jeanette versus Estelle versus Diane 35.
Yeah. Yes, man. Beautiful names.
Whenever I meet someone called Diane, I'm like, Diane 35.
Sorry, Diane.
But I just, like, all these names are based on the fact that the drug companies are giving them these names to differentiate themselves from another pill, which has got a different type of progestin and maybe a different amount of the ethinyl estradiol,
or different active ingredients that are working within them. Yeah, exactly. Yeah.
And so because of this, they can be used for different purposes, and this is why the pill is also used for different purposes outside of contraception, like improving your facial and body hair growth or acne, is because they're using a different type of progestin in that, which can dampen down your testosterone. So there's lots of different types and lots of different ingredients within them, and that's why if you're going to be on this, if you want to be on that for contraception, you might as well be on the best one for you. And there are so many of them. I mean, we would see, we're actually going to do some research on this and clarify the actual numbers for you, but at least 40% of people that we see are on the wrong pill for their symptoms.
Yeah, it is really prevalent.
Yeah, so. And actually they're on one that's making their hirsutism or acne, other PCOS kind of testosterone symptoms worse.
And that's like heartbreaking, because it's like, this thing that you're on supposedly to help, often been put on to help your PCOS symptoms, to actually find out that it's actually just been driving them as well, adding to those drivers. Yeah,
totally. So that's the combined pill. Then we've got the mini pill. So the mini pill, conversely, only contains one of those hormones. So it only contains the progestin. It doesn't contain the ethanoestradiol part. And this is why it can be good for anyone that's got like blood clots or a history of them or has had them themselves or any other reason why it's not safe for you. Or actually maybe breast cancer risk too. Another reason why this synthetic estrogen is not safe for you to take. So the way that the mini pill works is primarily by the later two things that we talked about before, which was the thinning of the uterine lining. So it stops the implantation, and also the thickening of the cervical fluid to stop the sperm getting up there and then meeting an egg. In some cases, it'll also stop you from ovulating. And it's interesting because I think that this is something that doesn't happen to everybody, but it can happen to some people. And I wonder if it's a genetic variation or just how your body responds to that level of progestin and going, hold on, this is not what my body produces. I don't want to, I don't know what this means. I'm not going to produce an egg.
Yeah, or like when you're having that level of progestin, which is kind of replicating progesterone, it's like we're not in a pre-ovulation state when that's kind of around, so it might not be prepping.
And it probably suppresses your body's ability to actually release estrogen, because those two things tend to work a little bit in opposition. Like when estrogen's high, it's growing the follicle, it's growing, and progesterone's low, and that's in the first half of your cycle. So if progesterone was high, maybe it's giving the signal to your body to not raise estrogen and follicle stimulating hormone and grow that egg. So therefore that's why it's stopping you ovulate. And that's likely why we see similarly people because you can take just the progestin part as like an anti-testosterone, an anti-androgen. We see that this used a little bit in place of spironolactone, and in some of those cases the person still ovulates, but in many cases they may not ovulate. And that's probably why that is as well. So it definitely works in those first two ways, the thinning of the uterine lining and the stopping the sperm getting up the cervix. It may stop you ovulating. Not sure. But there are some rules with the mini pill, right?
Yes, it needs to be taken around the same time every day, and that's because the moment that we start to, give it a few more hours, we haven't had that constant exposure to those hormones, and things like the cervical plug, that mucus can start to thin again, and there's risk for the sperm to get through, or that uterine lining can slowly start to thicken again, probably more the first, but that can really reduce that effectiveness from 99% we typically see to about 92% effective. And so it's really important that you need to be taking these pills at the same time every single day, which for a lot of people that's just not possible, like if they were doing shift work or had like young children or something that really stopped them from being able to regularly take that pill. And gosh, I take a pill that I have to take an hour before I eat or something like that, and if I miss that for the day, I'm like, well, there's not really a time in my day that I can take it anymore. But luckily for me, that doesn't, that's not going to jeopardize my risk of pregnancy for the next few days, but with the mini pill that really does jeopardize its action or its effectiveness.
Totally. And I've heard of a lot of people who have had unplanned pregnancies on the mini pill for this very reason, that they didn't really realise the importance of taking it at the exact same time, or even if they did realise, it just wasn't sustainable for them to do that because they had young children or another reason why they couldn't take it at the same time every single day.
I have a friend who fell pregnant because she got a tummy bug whilst using the mini pill and didn't really realise that she wasn't actually absorbing enough of her medication before she was expelling it from her body. That it was, she kind of had 3 days where she was sick, with 3 days where she didn't have that consistent intake of those hormones, and whoopsie, there was a wee baby.
Speaking of whoopsies, probably a good time to also talk about the morning after pill, which is also known as the ECP or emergency contraceptive pill, as a form of contraception, and because this is taken orally, so we're talking about the oral ones at the moment. So this one here works by trying to delay your ovulation, which I think is so important to understand, because so many people take it and don't really know how it works.
They think it's like a guarantee, right? It's like, okay, well, I've taken it now, the egg must be gone.
Yes.
I don't know, yeah.
And I know that different people have different feelings about emergency contraception based on their maybe religious background, but we need to talk about it here because it is a form of contraception. And so the way that it works is by trying to delay that ovulation. So the only time that you can get pregnant is approximately 5 days around ovulation. And that's because sperm will survive for approximately a maximum of 5 days.
Yeah.
And so, as you said before, we need to have sperm waiting there in the fallopian tube for the egg to be released in order to get pregnant. So if sperm are surviving for 5 days and then we're nearing ovulation and we take the ECP will push that out by a couple of days, then the sperm will die before we ovulate, and therefore there will be none left there unless you've had unprotected sex again in that time. And that's also very common. People think, okay, I've taken the ECP once this month, therefore I can't get pregnant. That is not how it works. It's just going to delay your ovulation by a couple of days.
Yeah, and sometimes as well, they'll often, and this is why when you go to a pharmacy to collect an ECP, they'll ask you a few questions around like, well, when was your last period? They're trying to gauge when they think in your cycle you're going to ovulate. They're probably using the 14-day calendar method as well, which has its other reasons why that cannot be so effective, but they're trying to gauge, okay, how close to ovulation are you? Will this work? Because like you said, it actually only pushes your ovulation out a few days, and there's still risk that it's not going to time quite right, and that sperm will still be alive and the egg will still be released.
Totally. So I think what often happens is that you were so close or just on ovulation, and therefore there's no way that the ECP can actually delay that.
Because the egg's already...
it's already in motion, right? It's like the plane is already taken off.
Yeah.
We
and
can't...
you've missed it. Your bag's not getting on there.
I was more going down the route of like the controllers out there like trying to wave it down. It's no way, can't happen. No way, can't happen. It's like we're already in motion. So that's why it's really important to know how this works, so that then you can think, okay, is this actually going to work? So if you're super close to ovulation, then actually, and you really do not want an unplanned pregnancy, then there is another method that we can talk about in a minute. It's a implantation device, so we'll talk about it when we talk about them, but that is the copper coil, and that's actually the most effective form of emergency contraception because it's the way that it works. So the other thing too is that if you understand how this emergency contraception works, if you know that you are, and many people with PCOS don't know when they're leading up to ovulation, and this can be a little bit hard, but if you do know that you've already ovulated, well, you can't get pregnant anyway because you've already released that egg, so you don't need to take emergency contraception, right? And that's why it can be really helpful to understand a bit about your cycles and where you are.
And I think it's really important to note too that like the ECP is a huge dose of hormones too. Like you've got to think about how much you'd have to take to really delay something like an ovulation that's already, the dominant egg has already been kind of selected and things are kind of heading that way. Just know that there can be, you're taking a lot of hormones at one time, and there can be kind of repercussions sometimes for like further cycles going ahead too. So just something to think about if you're maybe considering relying on these as like a regular option. Like just know that there's still kind of side effects that can happen from taking those too. Yeah,
definitely ongoing effects. And also, this is why if your period is delayed by a few days when you've taken the ECP, this is exactly why, because it has delayed ovulation. So the next one would be the more sort of longer term contraception options. So the first one would be the Depo-Provera injection. Not quite as popular as what it was when I was at university. I think probably because now there's even better options. I think when I was at uni, it was like, you either had to take the pill every day, or the Depo-Provera injection, you get one injection every I thought it was 6 months then, but it might be every 3 months. And therefore you didn't have to think about it over that time. And so it was this convenience factor. Whereas now there's a lot more longer term methods like the Mirena and the rod and other things that are
like 5 years.
Far more convenient than having to go and get the injection in your bottom every 3 months. So the way that the Depo-Provera injection works is that it's a large dose of that progestin. So it's only, again, just like the mini pill, it's only got that progestin part. And then it slowly reduces throughout those 3 months. So the same way that the mini pill's working, it's thinning that uterine lining, it's thickening that cervical mucus so sperm can't get up there. And then in many people, it might stop their body from ovulating because it is such a whopping great dose. right? Like they are injecting with quite a big dose, and so therefore it's giving that signal to your body like, whoa, progesteron's high, so therefore this is not time to raise estrogen, not time to raise follicle stimulating hormone, and therefore create an egg. So it is suppressing that in most people, and that's why most people will not get a period while on the Depo-Provera injection.
Yeah, because they're just not having that, you know, as we were talking about earlier, period as a result of ovulation. Ovulation's not happening, period's not happening.
Yeah, exactly. So yeah, I don't see it as common these days. Have you seen many people on it?
Yeah, no, it wasn't really common by the time I was of contraception taking age. Yeah, it was things like the rod were just coming out, so people were kind of like, that was the new tech, I guess, like that was the new thing, so people were kind of jumping on that bandwagon. But as well, I think by the time that I was starting to take contraception as well, a lot of, well, to be honest, I wasn't a big user of it. It never actually agreed very well with me, so I was only ever on the pill for like a week maybe, and then I just figured it's not for me, and that's okay. But I remember really being scared by being told by the harsher side effects of like more of the injections or the implantations, and I think particularly it was just kind of scared into us that like you'd gain so much weight if you were taking them. So I think they were always, everyone was just sort of like, maybe not. Yeah, the convenience doesn't outweigh like the risk of that. Yeah.
And probably because you were in like your rowing circle, that was probably quite prevalent knowledge, whereas it might not have been
in
elsewhere.
other cases. Yeah, I guess so. And, you know, like being in a sport like that where performance is important, that was kind of something that you really wouldn't want. Yeah.
Yeah. Yes, a very weight-dependent sport, and therefore, I mean, comes with a lot of challenges. But
yeah, when they're ranking you on your weight-to-power ratio, yeah, there's all sorts of problems that come in there. Yes. Anyway, that's a discussion
very
for another
side
day.
discussion. But so going back to the weight gain, that is a very real symptom of the Depo-Provera injection, and this came out. I think the paper was last year or the year before. But where it was quite a big group of people, and they randomised them into 4 groups. The Depo-Provera injection, the rod, the pill, I think, and then there was people on the copper IUD, which is non-hormonal, and they then tracked them over the next year or so, and they found that the Depo-Provera injection did cause significant weight gain. And that was about 6 or 9 kilos. We did do a podcast episode of this, so I'll be able to check that out again, but it was significant. And the rod was also quite significant as well. And a lot of that is because of the type of progestin that they're using in it. So the type that they're using is kind of pro-testosterone, and that's why I would never recommend the Depo-Provera injection to anybody with PCOS. I'm like, it's just not going to help your symptoms.
It's going to become a driver as well. Yeah.
It's
so whilst insulin's a driver, whilst stress could be a driver, using this medication the contraception could be a driver. Yeah.
Because it is actually increasing that testosterone as well.
And that's kind of what we talk about when we say that when testosterone increases, that can cause insulin to increase, can cause weight to increase, and it's that like negative cycle. So particularly if you're like susceptible to insulin not functioning that well, that could really like fast track that weight gain cycle for you. Yeah.
Absolutely. And I'm sure there's lots of people that are listening that are saying, oh, well, I used the Depo-Provera injection and I didn't. Yeah. That's, that's why not 100% of people in these studies did gain weight, but on average, that was the weight gain. So some would have been much more than that, and some would have been nothing, and that's just how your body and your genetics work. But generally, it's one that I would just say blanket, not a great idea, unless there's
other better options.
Yeah. I can't think of any case where I'd be like, this is a good option for you.
Yeah.
It would be. I mean, I'll be happily proven wrong, but I just can't think of anything at the moment that I would recommend it to someone. So that's that. Then the next one would be the rod. So this is implanted into your arm. So some of the brand names would be Implanon would be one. Then there's also Norplant, Gel, Nexplanon, Sino-Implant, Zarin, Femplant, and Trust are some of the brand names. So there are 2 different variations, or 2 most common versions, the single rod and the double rod. And again, the different ones and the different brand names generally mean there's different types of the progestin and different amounts of the progestin in them as well. So the way that these work is that they're implanted into your arm and then they slowly release that progestin over time. But like the Depo-Provera injection, the amount is quite a lot higher than the mini pill. So I think with most people on the rod, they find that they don't ovulate, so they don't get a period. And so it is suppressing ovulation, and then it's also doing those other things of thickening the cervical fluid so that sperm can't get up your cervix, and thinning that uterine lining.
Yeah, and they tend to be about a 5-year duration, and then you would have to have them changed. But yeah, there is other things to consider about actually having them implanted in as well. It is like a procedure. I think it takes like an hour maybe, and so whilst it's only every 5 years, there is like a minorly invasive procedure to have it done. So yeah, just things to like weigh up as well for you. Yeah
Again, the rod is one that I would be hard pressed to find to recommend to someone with PCOS, particularly because the types of progestin that they use. So again, I think there would be better long-term options for someone with PCOS. I can't think of a single use case at the moment where I'd say, oh yes, the rod is definitely the right thing for you.
Yeah.
And I know that we mentioned about this before, but we talked about the weight gain, but a lot of anecdotally, now that I would say this is anecdotally, I have heard a lot of people talk about the mental health consequences of the rod as well.
Yeah, interesting. I haven't been privy to that in conversation. Yeah.
And I know that this is something that is emerging all the time about hormonal contraception, but yeah, that's just one thing. And I would say again, that's very anecdotally about people that I've talked to. A lot of them didn't have good experiences on that.
Yeah, wow. And then like, you know, we can sit here and say, oh, that's not research, but this might not be researched that well. So, you know, some of the most powerful evidence we have is anecdotally. So, yeah.
Well, women have been complaining about the mental health effects of contraception for probably near on 50 years. And it hasn't been until the last decade that that's really been investigated. And we've been told that, no, this couldn't possibly be happening. This is just a coincidence that this happened when you went onto the pill. Same thing as the weight gain. Oh, no, this couldn't possibly happen. It was just, you know, coincidence that you started eating more and exercising less when you went on contraception. I even remember one doctor telling a friend, I'm not saying that this doctor's bad, this was just her explanation of it, was she said, it's probably because you've just got into a relationship, that's why you were on the Depo-Provera injection, and so that's why you're now eating more, you've become complacent, was basically, you know, and like it was, I remember sitting around our flat talking about this and us being like, really? Your lifestyle hasn't changed though. Like, you might be like...
And also, like, if we think about it, women get labelled, oh, you're hormonal, you're crazy, that changes your mood, all these things. It's like, the hell do you think hormonal birth control is? Just taking synthetic versions of these hormones. Like, no wonder. Like, it blows my mind.
So, anyway. So this has been, you know, only recently been investigated, and we're now seeing some scientific proof that it does in fact have mental health implications.
But it's interesting that particular type has been more noticed. But again, it's like that constant dosing in it.
Potentially. And the other one that we're going to talk about in a minute, the copper coil, was also seen anecdotally as well. A lot of people getting anxiety from that. I definitely experienced anxiety on that. And again, there is no proof from that, but there are thousands and thousands and thousands of women online talking about it. And I'm like, when there's that many people, and also, you know your own body. Like, even if someone tells you there is no research to this is not, you know, not happening, you're like, but
intuition is pretty powerful. And if you suspect that this is the driver for it, then who's to tell you that you're wrong?
Totally. And there's so much variation between person to person as well. It's kind of like what I was saying with the Depo-Provera. Not everybody in that study gained weight, but a lot of people did. So if you didn't, and that doesn't seem to affect any of your other hormones, then go for it. But if you do, that is not the right thing for you if that's not what the outcome that you want. So regardless of what the research says, there's always variation between people.
Always nuance, right? It's like, even in some of the most widely taken medications, paracetamol, for example, not everyone responds to it, and not everyone responds to it well. Or, for example, like the COVID vaccinations and things, not everyone responded to them well. What science does is try and target the mass of the population, but there will always be outliers who don't get the desired effects from medications, vaccinations, all those things. And that is just the reality, that we're all built so differently that there's not one thing that could fix every single person.
Yeah, and that we have different genes which code for different enzymes. And this is the whole premise of pharmacogenomics, which is analysing your genes and then looking at what pharmaceuticals will actually work for you. I've done this test, pharmacogenomics test, to see which drugs I interact well with or poorly with, or what I would need higher doses on. And it's really interesting just having a look through and seeing, especially for things like pain relief, that my genetics don't work very well with opioid-based pain relief. And this was really interesting because when I found that out, my grandmother had been on a morphine derivative, and for, she was in her 90s before she passed, and she really didn't respond well to that. And I got to say to all my aunties and uncles and dad, I was like, oh, look, this is what my genetics say. This is probably what grandma's had and why she really
yours
didn't respond. And yours might too, because you're my dad. That was her response. You've probably got that too, Dad. So when he had his hip operation recently, he had exactly the same thing. And I was like, I told you this ages ago. And he's like, oh yeah, I forgot about that. But it's so fascinating to see how our genes work so differently with those drugs.
And we talk about this in OV as well, particularly around anxiety and depression medications, how different people respond particularly to that set of medications, and why there are so many variants of those. But it can take a while to test and try different medications to see what you actually react well to. And a lot of doctors actually don't necessarily want to hold your hand through chopping and changing these medications too. So utilising something like that, pharmacogenomic testing, can help you pinpoint what ones are probably going to be the best for you.
Yeah, we referred so many patients to that for anxiety and depression medications, haven't we? It's been, and it's just, it speeds up that process so much, which is super helpful. Anyway, massive side topic, but very interesting, and why you might not respond well to different hormonal contraceptives. So next one would be the intrauterine devices. So these are in your uterus, intrauterine.
That's a bit more of a more invasive procedure than the rod. For some people, quite invasive.
Yeah, and it is. It can be really, can be painful, make you feel quite vulnerable.
Yeah.
So brand names for this would be Mirena, would probably be the most common, but also Skylena. Again, they have different variations of this name. If you just kind of look up intrauterine device, you'll see what ones and what brand names are available to you. But again, these contain the progestin part only, and slowly release that, again, similar to the rod one, over about 5 years.
Yeah, they're just inserted into your uterus.
Yeah, and the reason for that is that they thought that maybe if it's uterus, it's acting more locally, and therefore we can get away with a slightly lower dose than what's acting in your arm actually has to travel through your blood to your brain to have that effect then to your uterus. That's the way I understand it anyway, is that the uterine ones acting more locally and therefore lower dose.
And that probably explains as well the mental health pieces.
Totally.
So the Mirena, which is, like we said, one of the most common ones, typically pro-androgenic progestin, but we do see it actually being quite helpful in the case of endometriosis, because it really can slow the growth of those endometrial lesions and really help with pain relief in that aspect as well. So whilst, again, like all the other ones we've kind of said, there typically are better options when we're just looking at PCOS. If there's other things at play like endometriosis, potentially the Mirena for that kind of pain relief, that could be something worth exploring. Yeah,
absolutely. So the way that the Mirena is working is to thin that uterine lining, to thicken that cervical fluid, and in many cases stop ovulation. Not all though, and this is again that genetic variation, but also because it is that lower dose of the progestin than say the rod, more people will ovulate on it, and especially if it's been in for a longer period of time. So maybe you might not ovulate on it in the early days, but as it gets closer to the 4 or 5 year mark, maybe that's when you start actually ovulating on it as well.
Yeah, and that's why some people start to see their period return kind of in those later years.
Yeah, that's so true.
Yeah.
So the next one is the implantable device. Now we're going to get into the non-hormonal options. And sticking with the intrauterine one, the first one would be the copper coil. So the copper coil is non-hormonal. It doesn't produce any hormones. It instead is made of copper. The way that this one works is so fascinating.
It's so fascinating.
So because it's non-hormonal, it can't really change the physiology. It can't stop us from ovulating, so you still ovulate on the copper coil. But the way that it actually works is by cutting off the tails of the sperm so they can't swim.
It's spermicide.
Yeah, it is.
It's so interesting. So yeah, it's like it forms this like barrier because it's like forming an army against the sperm like inside of you. So that's why we kind of refer to it more as like a barrier option, because it's not changing the physiology, it's not hormonal, but yeah, it's really getting those sperm.
And it is incredibly effective. So it is the most effective form of contraception, which again blows my mind. That something as simple as a mineral like copper can actually be more effective than hormones in that way. So in that way as well, quite powerful, and really good contraceptive. As we mentioned before with emergency contraception, this is the one that if you are really close to ovulation, the emergency contraceptive pill may not work because it may not be able to delay your ovulation by enough days for the sperm to die. Then if you really don't want an unplanned pregnancy, getting the copper coil inserted could be the right option for you.
As soon as possible,
And this needs to be, within, have a talk to your doctor about it, but I think it's sort of like try it within 24 hours or so is the idea. But the way that it's working is by cleaving off those sperm tails. And to stop then from being able to even get to that egg. So like the marina intrauterine, so is
a bit vulnerable,
inserted, and it
some people
can
do say they feel it sometimes as well. I think it can be like maybe slightly uncomfortable if not inserted correctly.
Well, you do have kind of like two sort of strings hanging down, so some people do notice that they feel those, especially maybe if they're like inserting a tampon or other sanitary item. So I think too, for a lot of people, they find the pain quite tough when they're actually getting that inserted, and then also can experience quite heavy periods after it. So
sometimes a little bit of more prolonged bleeding, like it's not necessarily like it might look like what we call intermenstrual bleeding sometimes too. It's longer than your normal period, and like you said, heavier as well. But
the pro things is because it's not stopping your body from ovulating, you're still producing your own estrogen and own progesterone, but because you have that copper there, this can disrupt the really fine balance between zinc and copper in your body. So we have a really tightly controlled balance of zinc and copper, and if copper gets a little bit high, one of the side effects of that can be anxiety, and this is why I think a lot of people do, well, not a lot, but I think this is why some people can experience anxiety when on the copper coil.
Yeah, and that's something that you experienced, wasn't it? Yeah.
And I had never experienced, I'd experienced a lot of nervousness, like the kind of nervous anxiety about racing when I was an athlete. And so I knew kind of what that feeling was, but I'd never experienced chronic anxiety until I went on the copper coil. Because I wanted a non-hormonal method. And it again was one of those things that it wasn't until I was like, hold on, what's going on here? I'm suddenly experiencing this anxiety.
What's
changed? And kind of looked back and was like, this happened at the same time as I got that. And it's really hard because you do second guess yourself. You're like, but also I was like, moving moving houses, or there was this change, and maybe it wasn't just that, but I kind of just trusted that intuition a little bit, and I was like, well, worst case scenario is I can always get it put back in, right? Like, yes, it's a bit painful, but I didn't find it too bad, so I was like, that's okay. I'll get it taken out and I'll see how I feel. And it was really obvious, the difference, literally within a few days. So I was like, okay, this is not for me.
And so, like you said, you're not even someone who's predisposed particularly to anxiety. So, if that's something that you're already battling with, just maybe being aware that could worsen it for you.
But I think I am a bit predisposed to low zinc.
Yes.
It's been quite interesting. I had some recent tests done and my zinc did come back low, even though I've been taking zinc for quite a while. So, I was like, maybe that's why. Because I'm sort of a bit predisposed to that lower zinc and therefore that imbalance.
It maybe.
So that's copper coil. Then the next things in terms of non-hormonal methods would be the fertility awareness method. And I'm only going to that next because it's the next most effective. So the fertility awareness method is using your body's signs and symptoms of knowing when you're fertile to avoid contraception or using a barrier method during the times you're fertile, and then knowing when you're not fertile and not having to use barrier methods for that. So fertility awareness method often gets a bad rap because there are different kind of variations of this, or people think that they're doing the fertility awareness method where actually they're just counting the days of their period and then making a random guess about when they're going to ovulate. And that is not very effective. So if done well, the fertility awareness method is 98.9% effective, which is pretty much as effective as the pill. Remember, the pill was 99% effective. But again, that's with perfect use as well. So you've got to know how to do it, you've got to follow the rules, and you've got to follow the rules quite consistently in order to get that level of effectiveness.
Yeah, and this is really just around the timing piece. So it's like if you know when you're about to ovulate and you put something in place, be it a barrier or a pull-out method or whatever it is, to stop the sperm from meeting that almost coming egg, then you kind of know within like that 5-6 day window, okay, we need to be extra careful here. But that's the only time during my cycle that I actually can get pregnant.
Yeah.
Any earlier, the egg won't be there yet. Any later, the egg's already out. The sperm cannot fertilize the egg once the egg's already released. The sperm has to be there waiting. So it's kind of that pre-ovulation phase that we just have to be aware of, be able to recognize the signs and symptoms in our body to pick that up. And then we can, that's almost like once you start to read your body, essentially, it's like your body almost gives you these signs like, hey, I'm ovulating. Don't you even think about it if you don't want a baby. And and so I think this is both you and I use this form. And I think it's really, not only does FAM help you with the contraception part, knowing how to use FAM on the flip side, when you want to come have a baby, you can use that to help you time and not shoot in the dark, essentially, when you want to have the baby. But then as well, it also, once you're aware of where you are in your cycle, it gives you that whole holistic view of why you might feel certain ways at different times of your cycle, because you know, hey, I'm in my follicular phase, hey, I'm in my ovulation kind of phase, hey, I'm in my luteal phase, and that can really help guide all the other things, like certain ways of eating or exercise, or however it's sleep potentially, if you want to kind of tap in and be more in tune with your body that way too.
It is one of those teach a man to fish type scenarios, right? Like once you've learned how to use it, it is a skill set for life,
and it's free.
And it's completely free.
Completely free. You don't have to get an injection, you don't have to go back in 5 years to relearn it. Like, it is just a skill set that you will just use and use and use until menopause.
Literally.
Yeah.
And it is so useful. I think that this
and
is,
useful as contraception, useful for conception.
Useful for body literacy, awareness, everything. And a lot of people don't think that they can use this because they have irregular cycles if they have PCOS, but that is not the case at all, because we're using your body's signs and symptoms to tell you when your body is trying to ovulate and then when it has ovulated. Because that's, if you're getting a long cycle, that's what's happening, is your body is trying to ovulate probably multiple times before it's able to, but we can use those body signs and symptoms to understand that and then understand when you have actually ovulated, so that you can use this just as effectively as anybody else.
And then as well, like you're saying, like the body literacy part or the cycle literacy part, you can also really use this to recognize, is there kind of deficiencies in my cycle? Like, is my luteal phase like a little bit deficient? And, then once you know these things, then you can kind of put plans into action to kind of improve those too.
Next ones would be the barrier methods, really. So these could be either like a physical barrier, so we're talking condom or diaphragm, or a spermicide, which is again kind of similar to the copper coil in terms of that it's actually damaging the sperm to stop that getting through there, but isn't necessarily a physical barrier.
Talk me through the diaphragm, because that's not something that I'm like super familiar with.
I use a diaphragm. I think they're really convenient. So a diaphragm or a cervical cap is another one. So these are like little dome, like it's like a dome shape, and I like the diaphragm's a little bit. It's a slightly different shape. If you're watching this on video, I am like showing you what that looks like, but it's sort of like a bit of a ovally shape, and it's got like a a curve to it. And so what you do is you like squeeze it. So squeeze it like you would maybe like a menstrual cup. Yeah. And insert, so it's like long, and then insert it, and then so it covers the full cervix. But it's like a dome sort of thing, soft, like a soft dome. So it's got like a more of a harder rim, and then it's like quite a soft dome. Whereas a cervical cap is more silicone-y like your menstrual cup, but again it's more like a dome, so it's a lot shallower than a menstrual cup, but it is quite a lot smaller. So I think that the diaphragm, the reason I like that is because it is that bigger, so you don't have to be as, I guess, precise with where you're putting it, whereas the cap's like quite small, so you want to make sure that you've literally got it right over the top of that cervix. Super convenient in the fact that you just insert once, and then that can stay in for like 8 hours, probably 24 hours. I can't remember what the guidelines they give, but let's say 8 hours is probably a safe amount. But because it's made from kind of like silicone, it's not like you're not at risk of like toxic shock syndrome or anything like that. But yeah, it provides that really good like barrier. So a lot of people can combine like the diaphragm or cervical cap with a spermicide. Like some people might combine the two. I've never really combined the two, but if you want that extra layer of protection, then you can use a spermicide to thicken the cervical fluid to stop that sperm from being able to get through there. So that's if you want that.
And that's the thing is with all these methods, like you say, you can layer them as well, you know, like you can use FAM and a barrier method, you can use the pill and a barrier method, you know, you can layer them as well if you're concerned about potentially you have been on the pill, the mini pill, you think that you've taken it a bit later that day, you know, that you've always got the option there. And I think one thing to note as well, which we don't talk about here at all, but like obviously certain barrier methods are going to protect against STIs, which, you know, none of the other contraceptions necessarily are. So
absolutely. And so, if you use the fertility awareness method and you completely abstained in those, say, 5 days before your cycle, then that would be a barrier method, right? Because there's no sperm going to be getting there. So that can be one way. Or in those days before you ovulate, in those fertile days in your cycle, you could use something like a barrier method like a condom or a cervical cap or a diaphragm, as well as a spermicide, and then maybe as well with withdrawal method as well. Like, so the withdrawal method also gets a lot of, I guess, like laughing.
Heat.
Because it's like, it's not a method. It is. It absolutely is method. And even if you just used that, if you just used the withdrawal method, I think it's like 60% effective, right? So it's not great.
No.
But like that's
in combination, exactly. So it's like, okay, here's another way we can stop as much, you know, sperm getting there. I think the withdrawal method, when I did my fertility awareness training, they said the main problem is that as a female, you're not in control of that. And sometimes the male isn't necessarily in control of that either. So that's why it's not like a great one to rely on, but used in combination can also be helpful. Kind of like layering effectiveness.
Exactly. And then I think everyone's pretty, I guess the female condom's another one. I don't really know too much about that.
I don't know about it either. I haven't utilised it, but
I just can't understand, like, all I can think of is like a male condom. I'm like, how does that like then stay?
Work? I don't know.
Anyway, not something, but
mechanics of that.
I think that probably if I was going for an internal, like that's why I think the diaphragm's really effective and easy. So I'd probably recommend that one.
Nice.
Just because it's what I know. So I guess the other method is the calendar days counting method. And again, this is one that I would not recommend because it is
probably the least effective. Of all.
Especially if you've got irregular cycles. So this one just uses you counting when your period is and then assuming that you're going to ovulate on day 14, or you're using an app which will use an algorithm to assume when you're going to ovulate or try and predict when you're going to ovulate. But especially if you have irregular cycles, that prediction is going to be wildly inaccurate. So consequently, this kind of calendar days counting is about 60% effective.
And like, when you think about it as well, if you're relying on an algorithm or a calendar to tell you when you think your going to be fertile, you're missing all those body signs as well that can tell you.
I just would say that if you are doing that at the moment, it's probably because you're not aware that isn't the way it's done, because you've just been like, maybe someone said they're using a certain app, and so you've used that and maybe don't know the rules about the other fertility awareness method stuff. So I would encourage you just to learn, because it doesn't take very long to learn these things and to start to take some of these signs and symptoms of your body. And as we said before, once you've got that, then it is a skillful life. If you're finding value from these podcasts, then we'd be so grateful if you could hit follow on the PCOS Explained podcast. This means that not only you'll get the latest releases, but also that other people are more likely to find this podcast. That's the way the algorithm works. And we all know how important it is to get good information about PCOS. So if you can hit that follow button, it means that people with PCOS that don't know that this podcast exists are more likely to find it. So thank you so much for your help there. Now stand by for our disclaimer. The information contained in this podcast has been prepared for the purpose of providing information, including about the PCOS nutritionist products and services, and is designed to support clients' overall wellness. It is not intended to provide medical advice or designed to rectify, treat, or cure any specific medical conditions or diseases. Nothing stated or shared in our podcast is intended to be and must not be taken to be medical advice. Please seek the advice of professionals as appropriate regarding the evaluation of any specific information, opinion, advice, or content contained in our podcast.